Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Extract 1. Questions 1 to 12.
In this part of the test, you will hear a doctor in a general practice surgery interviewing John Scott, the father of Brett, a young patient with a problem that started recently.
For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Doctor. I'm John Scott, and I've brought in my 5-year-old son Brett to see you.
Right, so what's been the problem with Brett?
Well, he's just been a bit sick and off colour over the past 24 hours.
Okay, could you tell me a bit more about that, please, John?
Well, we sent him to kindergarten as normal yesterday morning, and they sent him home early, just saying that he seemed unwell and refused to play and take part in the kindergarten activities. And he didn't really want his tea and felt a bit feverish and a bit hot, and wanted to go to bed early, which is very unusual for him.
Mm-hmm.
He woke up a couple of times during the night, just complaining of some stomach pain. He seemed a little better this morning, and we gave him some Panadol, and I think that helped him a bit. But he's still not himself, so we're a bit worried about what's going on here.
Right. Has there been anything else that you've noticed that's different from normal for him?
Well, not really. As I said, prior to yesterday morning, he seemed perfectly well, and was his usual bouncy, cheery self.
Mm-hmm. Okay. Has he had anything like a runny nose?
No, we haven't noticed that.
No, does he seem to have any pain anywhere?
Well, he's commented a couple of times about just pain in his stomach, actually. He's sort of put a hand on his stomach and indicated that's sore, Daddy. But we don't know what to make of that.
Right. Has he had any vomiting?
He's vomited a couple of times, vomited overnight. He vomited twice overnight.
Right. Any diarrhoea?
No, not that we've noticed.
Okay. Any other problems with his bowels?
No, as I said, he's been otherwise pretty well lately.
Right. And any problems with his waterworks that you've noticed?
No, I don't think so.
Okay. Has anyone else at home or at kinder been sick that you know of?
No, we have another child, that's Robert. He's 7, a bit older, and Robert's been really well, and my wife and I have both been fine. So we really are at a bit of a loss to explain why he's this way.
Right, I see. Perhaps if you can just go back a little bit now and ask a few general questions. Has he had any major illnesses in the past at all?
Well, he's had chicken pox, and he's had the measles already, and he does suffer a bit from eczema of the skin, mainly affecting his elbows and his knees, and we occasionally need to use a special cream for that.
Mm-hmm.
But that's a fairly minor problem, and it goes away if we put the right treatment on it. Apart from that, he hasn't had anything of major significance.
Right. And have you taken him to see any other doctors during this particular illness?
Well, not this one, although I must say that this is not the first time this kind of thing has happened to Brett. I mean, he's had 2 or 3 episodes of this sort where he's become hot and feverish and felt unwell and complained of a bit of tummy pain. And we've taken him along to doctors, and one of them said that this was a type of abdominal migraine.
Mm-hmm.
My wife actually suffers from migraine headaches, and the doctor then explained that children can sometimes inherit this tendency and have, stomach pain instead of the headache. So he just saw it as something that would sort of come back a bit and maybe was a bit passed down from his mother.
I see. Okay. Any other illnesses in the past at all?
No, other than that, he's been well.
Hmm. And apart from the cream for his skin, is he on any other medications at the moment?
No, none at all.
Okay. Is he allergic to any medicines that you're aware of?
He was allergic to cow's milk as a youngster, and we had to get a special infant formula for him when he was a baby. But apart from that, he seemed to have grown out of that tendency, in fact, so he can have cow's milk now. And apart from that, I don't think he's allergic to anything.
Right. Is he up to date with all his immunisations?
Yes, he's had all his triple antigen and tetanus and all those sort of things, yep.
Hmm. Okay. Do any illnesses run in the family that you're aware of?
Like what?
Do you or your wife have any illnesses?
No, apart from my wife's migraines, we're both pretty healthy, in fact.
Hmm. And your brothers and sisters?
No, they're all fine.
Extract 2. Questions 13 to 24.
In this part of the test, you will hear Dr. Jean Matthews interviewing Michael Fraser, a patient with a recent problem.
For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Michael. Come on in and take a seat. My name is Jean Matthews.
Hello, Doctor.
Well, can you tell me what's brought you here today?
Well, to be honest, I haven't been feeling well for the past week or so.
That's no good. What sort of symptoms have you had?
I've had a fever for a few days. It comes on worse in the afternoons as well.
Mm-hmm.
I have been feeling a bit nauseous as well.
And are you taking anything for that? Panadol, things like that?
No, I haven't. I've just been trying to tough it out.
Okay. And what about your eating habits? Have you noticed any change to your appetite?
Yeah, well, I don't seem to be as hungry. I haven't been able to complete my meals without feeling a bit sick.
And with the nausea, has it ended up in vomiting?
Yeah, I did vomit actually, both yesterday morning and this morning. That's one of the reasons I thought I'd better come and see you.
Okay. And what about any other aches or pains generally?
I'm feeling a little bit tired, and I've had a few pains in my joints, and I've been a little bit stiff in the mornings.
And have you noticed any other sort of changes, such as yellowish skin or in the whites of your eyes?
Well, I didn't, but my wife commented this morning that she thought my skin had turned a bit yellowish.
And what about the colour of your urine? Any changes there?
Now you mention it, I do think it's become darker in colour.
Okay, I see. Now, Michael, I'd just like to get some background details before we go any further. Could we start with your age, please?
I'm 38.
Are you married?
Yes, I am.
And any children?
Yeah, I've got 2 children.
And how old are they?
I've got a daughter who's 9 and a son who's 11.
Oh, lovely. Okay. And what about your employment? What sort of work do you do?
I'm a carpenter by trade.
I see. And you work mainly on building sites and places like that?
Well, I do work on building sites, but the company I'm currently working for now has quite a few overseas projects, so I do go overseas quite a bit with my work.
And whereabouts have you worked recently?
Well, this year I've been to East Timor, and I've just come back from New Guinea about 10 days ago.
I see. Okay. And just tell me a little bit more about your general health.
Well, pretty fine, I think. I eat healthily, and I haven't had any complaints.
And do you smoke at all?
I do smoke, but I try to keep it under control. suppose I smoke about 10 cigarettes a day.
Okay. And what about alcohol?
Well, I have a couple of beers most days, but my wife and I are trying to be responsible and have a couple of alcohol-free days each week.
Well, that's an excellent idea. Okay, very good. And now, just to go on to your family history, what about your parents? Are they in good health?
Yeah, they're both in quite good health. My father, he retired a couple of years ago, but he's fine. And my mother, she's well. She does have high blood pressure, and she does take some medication for that, I believe.
Okay. And do you have any brothers or sisters?
I've got 3 sisters, and they're all well.
Okay, good. Well, Michael, your blood pressure is certainly excellent, and you're not overweight.
I'm pleased to hear that.
But what I do think, based on your symptoms and the jaundice and everything you've told me, I'm a little concerned that you might have hepatitis A.
Really?
Well, this is not something to be greatly alarmed about, but it may be connected with your overseas travel. It's spread through fecal-oral transmission, and it may be that you've touched something and that's been contaminated, for example.
That is the end of Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Amanda Wagley with the song called Amanda's Dance, which she wrote about her experience of hearing voices. Today we'll hear about a compassionate approach to treating people with distressing symptoms of psychosis, such as auditory hallucinations.
Now read the question.
In his practice, psychologist Charlie Heriot-Maitland observed that people like Amanda, who hear voices, are often treated in very punitive ways. His research also showed that voice hearing isn't always associated with psychosis. Some people in the general population hear voices as well, so he felt it important to change the approach to treatment.
Compassion-focused therapy offered a really good normalising model because it's based on the human brain, the evolved, tricky brain, and the whole approach to therapy comes from that premise of normalising, de-shaming, developing relationships with experiences from that place.
Can you explain to me, first of all, what compassion is?
Well, that's a tricky question. We often start our workshops with a whole section on trying to get our head around what it is.
Question 26.
Indeed. Professor David Henry is at Bond University and the University of Melbourne.
Now read the question.
I mean, for example, just to set some context here, David, I mean, we were international leaders in Western Australia in linked hospital data. There are linked data units in every state and territory now, and probably most of the states and territories are ahead of WA now. And you've got the 45 and up study in New South Wales, which links all the data you're talking about. So what are we missing?
So at population level, what we're missing is the ability to link routine. only the state data you've been talking about, you're mentioning there, and the Commonwealth data, which contains essential information like prescription drugs, like consultations with GPs and specialists, a number of other procedures. And that information is not routinely linked to the state data, whereas in Ontario, it is.
Question 27.
Damien Finnis is a clinician and researcher in anaesthesia and pain management at the Royal North Shore Hospital in Sydney.
Now read the question.
The main findings are that there isn't actually one placebo effect. There are many of them. And in the setting of pain, for example, we know there are very specific mechanisms in the brain and even in the spinal cord which are turned on when you give a placebo. And we know they involve various different neurotransmitters, if you like, the endogenous opioids, to name one, and even the endogenous cannabinoids receptors. So they're very discrete, and we're really appreciating that placebo effects are actually very specific and very targeted.
Tell me about a placebo effect that has been shown to really work and what the mechanisms are that are operating there.
I think most of the elegant studies occur in acute pain, either in the experimental or the clinical form, and there are multiple studies which show that if you were to give somebody a real drug like morphine several times and then replace that with a placebo and add verbal suggestions that that placebo would be a powerful painkiller, if you like, that activates the endogenous opioid system to cause relatively dramatic reductions in pain in the short term in acute pain.
Question 28. You hear.
Dr. Caitlin Curtis is a research fellow in the Centre for Policy Futures at the University of Queensland.
Now read the question.
GEDmatch was designed to be an open-source ancestry tool, so genealogy enthusiasts could track down relatives. But this also means that the system is available for police investigators to use. Decades ago, police had collected a sample from the crime scene, but a genetic sample isn't much use unless you know who it belongs to. Police thawed out this frozen sample and used it to create the same kind of data that ancestry companies do. Then they submitted it online and compared it against GEDmatch's existing database. The police didn't locate the suspect through their search on GEDmatch because his DNA wasn't uploaded. They didn't even find a close relative. What they found through GEDmatch were a number of third and fourth cousin matches to their unidentified samples. And these are distant relatives. Third cousins share a set of great-great-grandparents, and on average, we all have somewhere around 190 third cousins.
Question 29. You hear.
Greg Dorr heads the Hepatitis Clinical Research Programme at the University of New South Wales Kirby Institute.
Now read the question.
Okay. We're also doing a large study in New South Wales in 2 maximum security and 2 medium security prisons where we've been monitoring transmission of hepatitis C, and we've been rapidly upscaling with these new therapies over the last year or so, and we'll look at the impact that treatment has on transmission in the prison setting.
So the prison officers are allowing you to treat prisoners with hepatitis C?
Yes, it certainly took a bit of explaining, but I think one of the key things for them is that to remove hepatitis C from the prison setting, for them, reduces their occupational risk of acquiring hepatitis C.
Now, the target is elimination. Is that realistic?
Look, I think it's realistic under the WHO definition, reducing the number of new infections by 80% by 2030. So I think those goals are certainly feasible in the Australian setting.
What about globally?
Globally, look, it's a tough ask. Only 20% of people with hepatitis C globally are aware of their infection. In 2016, for example, about 1.5 million people were treated, but more than 1.5 million new infections occurred. So we're just sort of treading water.
Question 30. You hear a...
Lloyd Swinburne is Professor of Population Nutrition and Global Health at the University of Auckland and is also Director of the WHO Collaborating Centre for Obesity Prevention at Deakin University in Melbourne.
Now read the question.
So 2 studies published in the Journal of the American Medical Association. So that's a prestigious journal. They're 2 big trials. So I'll talk about the one that was unsuccessful first. So that was a trial of young children, age about 3 to 5, who are overweight but not yet obese. So the risk of becoming obese. They are divided into 2 groups, about 300 in each. So good size numbers in each arm of the trial. And most of them were Latino, so they were Hispanic Americans, and they were had relatively low education. So I guess, if you like, picking off the group that's really at most risk, the most disadvantaged populations, and the kids about to head into the obesity zone, if you like. So the interventions that they ran, and they followed them for 3 years, which is a good length of time to see an effect, but the interventions that they used were very behavioural interventions focused on particular behaviours of children and how to deal with those. And
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36.
In this part of the test, you'll hear a lecture on the topic of smoking during pregnancy.
You now have 90 seconds to read questions 31 to 36.
Good morning, my name is Sally and I'm going to talk today about the effects of smoking during pregnancy and the role of the health professional in smoking cessation. The umbilical cord is a baby's lifeline. The blood that flows through this cord gives a baby all the oxygen and nutrients it needs to grow. However, when a person smokes a cigarette, they inhale the gas, carbon monoxide, and this means that the amount of oxygen available to your baby through the umbilical cord is reduced. As a result, the baby's heart beats more rapidly and increases the overall stress on its developing body. This leads to a lower birth weight and a baby more prone to illness after birth. A baby of a woman who smokes weighs on average 170 to 200 grams lighter than that of a woman who doesn't smoke. The more a woman smokes, the greater the growth restriction of the baby. And of course, having a smaller baby is not a positive thing. A smaller baby does not mean that the birth will be easier. In addition, there is no safe level of smoking. Even a few cigarettes a day means your baby is exposed to the poisons that might affect your baby's development and growth. Reducing the number of cigarettes does not reduce the harm. Examples of problems associated with smoking during pregnancy include increased risk of miscarriage, increased risk of stillbirth, antepartum hemorrhage, a greater chance of preterm birth. The rates of preterm birth are 60% higher for mothers who smoke. Low birth weight, which results in a baby that is more vulnerable to infection and other health problems. Fetal growth restriction, sudden infant death syndrome, childhood respiratory problems such as asthma, and childhood behavioural problems. Smoking frequency among pregnant women in developed countries has been reported to range between 13 and 38%. These smoking women are often unknowingly causing great harm to their unborn child. A recent analysis of obstetric data for women attending antenatal clinic in a large public hospital in Australia revealed that 22% were smokers at the time of their first booking-in visit. Of these, approximately 50% smoked more than 10 cigarettes per day. And 40% of the women who are smoking are teenagers, that is, less than 19 years of age. Although population-based data on smoking and pregnancy is limited, it is clear that smoking rates are particularly high in Indigenous Australians, where the rate is approximately 50 to 60%. There are marked social differences between women who smoke in pregnancy and those who do not. Some of the major differences include low socioeconomic status, ethnicity. For example, in Aboriginal and Torres Strait Islander women, smoking rates during pregnancy are as high as 60%. Marital status, unemployment, low level of education, for example, not having reached grade 12. Pregnancy is a highly motivating time for many women to improve their health behaviours, and pregnant women are seen in hospitals on a regular basis. This provides an opportune situation to assist and support smokers in quitting. In implementation of best practice, hospitals should consider ways to overcome potential barriers to providing these brief interventions. It is also important that hospitals are encouraged to work towards a total smoke-free environment. If healthcare professionals provide assistance to smokers through smoking cessation interventions, there is strong evidence that the results are positive, including a reduction in smoking rates, a reduction in heavy smoking, that means more than 10 per day, a reduction in preterm birth and low birth weight. It is important to note that many studies have shown that women are less likely to quit smoking if their partner is a smoker, and this highlights the importance of providing support for partners to quit smoking as well. An effective strategy used by nurses and other healthcare providers in many public hospitals in Australia and abroad is the 5 A's approach. The 5 A's are ask, advise, assess, assist and arrange. Let's look at them one by one. Ask. Ask the woman about her smoking status, first by asking her if she has ever smoked, and if she replies yes, provide her with a range of responses that best describe her smoking patterns. The use of multiple choice questions is more effective than a simple closed or yes-no question and has been shown to increase disclosure of tobacco use among pregnant women by as much as 40%. Advise. Advise the woman of the health risks to her baby, her own health, and her other family members' health, and advise on the benefits of quitting at any stage during pregnancy. All advice should be given in a clear, non-judgmental, supportive manner. Assess. Assess the woman's readiness to quit to determine the advice and the support needed. Assist. Assist the women with smoking cessation support. Arrange. For all women who are ready to quit.
Extract 2. Questions 37 to 42.
In this part of the test, you will hear a lecture on the subject of skin cancer.
You now have 90 seconds to read questions 37 to 42.
Australia has one of the highest incidence of skin cancer in the world, at nearly 4 times the rates in Canada, the US and the UK. Over 200,000 Australians are treated for skin cancer each year, and it also kills more than 1,000 Australians each year, and many of these deaths are preventable. Sun exposure is the cause of around 99% of non-melanoma skin cancers and 95% of melanomas in Australia. In fact, 2 in 3 people who spent their childhood or adolescence in Australia will be diagnosed with skin cancer by the time they are 70, and GPs in Australia have over 1 million patient consultations per year for skin cancer. Skin cancer is predominantly caused by long-term regular exposure to ultraviolet radiation, UVR, from the sun. UVR can lead to abnormal growth of skin cells. If these abnormal cells are not destroyed by the body's natural defense system, skin cancers may develop. There are 3 main types of skin cancer. Basal cell carcinoma, which is the most common form of skin cancer at 75%. Squamous cell carcinoma, which accounts for 20% of all skin cancers, and melanoma, the most serious type of skin cancer at 5%. Basal cell carcinomas usually appear as a round or flattened lump or scaly area and is red or pale pink in colour. It grows slowly and is commonly found on the head, neck and upper parts of the body. They may become ulcerated and can be identified as a spot that won't heal, and about half of basal cell carcinomas recur after 5 years. Fortunately, they only rarely spread throughout the body, and in most cases they are curable. The most important predisposing factor in the development of basal cell carcinoma is the exposure to ultraviolet radiation, UVR, in sunlight. Squamous cell carcinoma is the second most common form of skin cancer. It may grow faster than basal cell carcinoma and metastasize if left untreated. Squamous cell carcinomas usually form a scaly, quickly growing pink lump or wart-like growth, which may also break down, crust, bleed, and ulcerate. They do not usually cause pain, but may be tender or cause a burning or stinging sensation. They most commonly occur in areas exposed to a lot of sunlight, such as the face, ears, scalp, lips, and the backs of the hands. It occurs with increasing age and frequently arises on the sun-exposed skin of middle-aged and elderly individuals. The incidence is more common in males. People who have had organ transplants or medications to suppress their immune systems for other reasons are at higher risk of developing squamous cell carcinomas. In transplant patients, squamous cell carcinomas are also more likely to grow quickly and metastasize. This makes regular skin checks and early treatment of skin cancers extremely important for people who have had transplants or have suppressed immune systems for other reasons. Geographically, both basal and squamous cell carcinomas are found worldwide, but are most common in areas with high levels of sunlight. In addition, the incidence decreases with increasing distance from the equator. There are also important genetic contributions to the development of these carcinomas. Risk factors relating to exposure and susceptibility to sunlight include Northern European ancestry, fair skin, childhood freckling, blonde or light brown hair, green or blue eyes, and a number of past sunburns. With basal cell carcinomas, it is currently believed that childhood sun exposure rather than cumulative sun exposure is the main contributing factor in the development of basal cell carcinoma in later life. In addition, short periods of intense sun exposure are thought to be more dangerous than a long-term exposure to a similar total dose. In contrast, squamous cell carcinoma is most closely associated with cumulative sun exposure.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.